Can pause the recording for now until we get started. I think I will do that just so folks feel like they can speak freely. So I will do that now and get it going once we get started.
Who's joining virtually? Do you have Ms. Collins? Please indicate if you're present.
I am virtual.
Great. Dr. Dixon in Las Vegas? Here. Senator Donyate joining virtually.
Here.
Attorney General Ford in Las Vegas.
Here.
Ms. Holmes in Carson City. We'll come back. Mr. Iverson joining virtually.
Good morning.
Ms. Johnson, Las Vegas. Present. Good morning. Ms. Lee joining virtually.
Present. Good morning.
Ms. Nadler joining virtually.
Present. Hello to all.
Ms. Jason joining virtually. Mr. Schoen, Carson City.
Yeah, good morning. Yes, I'm here, present.
Mr. Shell joining virtually.
I'm here.
Assemblywoman Thomas in Las Vegas. Here. Assemblywoman Holmes joining virtually.
I'm here. Thank you.
And Dr. Woodard joining virtually.
Good morning, I'm present.
All right, Mr. Attorney General, we have a quorum.
Very well. Do we still not have an appointee for Senator Settlemyre?
That's correct.
Right. I am going to quickly send a message. Okay, very well. Well, good morning, everybody. Happy New Year to you. If you are not talking, please mute your microphone because we're getting a little feedback already. Thank you so much. Okay, well, Happy New Year, everybody. It's great to see you all. Delighted to be with you for our first SURG meeting of the year. Again, if you are not speaking, please mute your microphone. We have reached agenda item number 2, which is the first time set aside for public comment. Is there anyone in the room who would like to speak a public comment on an item that is on the agenda? Anyone here in Vegas for public comment? Anyone virtual for public comment? Anyone in Carson City or elsewhere for public comment? Did we get any written public comment?
No.
Very well. Okay, we'll move on to agenda item number 3, which is a review and approval of minutes for our November 16th, 2021 SURG meeting. Please take a couple of seconds to review that if you haven't already, or a couple of minutes, maybe not seconds. I'll give you a little more than a couple of seconds. But once you've done it, I will entertain a motion to approve the minutes from November 16th.
So moved. This is Eric in Carson City.
Have a motion. Can I get a second?
Lisa Lee, for the record, I'll second that.
Dr. Dixon.
Dr. Dixon seconded it already. Great. So we have it's been moved and properly seconded that we approve the minutes from November 16th. Any discussion or corrections on the minutes? Hearing and seeing none, all in favor say aye. Aye.
Aye.
I'm sorry. This is Debbie Nadler speaking. In the minutes, I'm so sorry about this. There is one little correction where you were speaking about Attorney General, where you were speaking about combining prevention and treatment together. It says that I agreed with that in the minutes.
And you did not. Is that what you're saying?
That's right. I said they should be separate. It should be separate.
Okay.
Prevention and treatment. Yes, sir. Yes, sir.
Then I will accept an amended motion to approve the minutes as amended by Ms. Nadler.
So moved. This is Eric Schoen, Carson City.
And will you accept that second? Will you? Likewise, seconded. Any further discussion on the minutes as amended? Okay, try it again. Hearing and seeing none, all in favor say aye. Aye.
Aye.
Aye.
Aye.
Any opposed, say nay. Any abstentions? Great, motion passes unanimously. And please note for the record that we will have to fix that in the minutes. Thank you so much. Okay, moving on to agenda item number 4, annual report on the use of state and local money to address substance misuse and substance use disorders. This is a possible action, and I will be tendering the mic to Dr. Woodard, Senior Advisor for Behavioral Health, Department of Health and Human Services. Dr. Woodard, mic's yours.
Thank you. Good morning, Attorney General and SURG Committee members. This agenda item this morning is really for possible action and potential brief discussion. There is a section in the bill that requires an annual report to be presented to the SURG Committee from DHHS, and was hoping to review that section of the bill to have a discussion on potential limitations for gathering some of the information that is required for the statute, and to ensure that we have a clear path forward to satisfying this portion of the bill. So I'm going to pull something up here real quick. So I'll just read very briefly. The section of the bill requires that the Department of Health and Human Services annually submit to the working group a report concerning the use of all money received by the state pursuant to any settlement entered into by the state of Nevada concerning the manufacturing, distribution, sale, and marketing of opioids. All money recovered by the state from a judgment in a civil action by the state of Nevada concerning the manufacture, distribution, sale, and marketing of opioids. Any gifts, grants, or donations received by the state and each political subdivision of the state for purposes relating to substance misuse and substance use disorders, and all other money spent by the state and each political subdivision of the state for purposes relating to substance misuse and substance use disorders. So at first, I would like to open it up to the co-chair of the committee, Assemblywoman Tolles. She was one of the primary supporters and authors of the bill, just to get a better understanding from her around some legislative intent for this section to ensure that we at DHHS are able to meet the requirements of the legislation.
Councilwoman Tolles, mic's yours. I'm sorry, go ahead.
Thank you so much, and I appreciate the opportunity to see you all. I don't know if we could bring forward the Zoom so that we can see everybody's faces, since this is my first time getting to see you all. If we could stop maybe the screen share for a moment. There we are. Well, if you can indulge me for just a moment, I'd like to just introduce myself to this group, since it was unfortunate timing that I wasn't able to join you on our first meeting together. And I am beyond thrilled that each of you were willing to step forward and take on this incredibly important issue. If I may take just a few moments to explain my connection to this topic and our hope for this group moving forward, since we didn't get a chance to meet each other in the very first meeting. So I'm Assemblywoman Jill Tolles. I'm serving my third term in the legislature. And before that, I was an advocate. Like some of you who are part of this group and some of you who may be watching, I advocated for three sessions before that on issues regarding education and child abuse prevention. And that's what led my journey into public service, which I've been greatly appreciative of the things that I've been able to work on, including this. And I've lived in Nevada since I was 19 years old, went to school here, worked here, raised my family here. And like so many across Nevada, I've personally been impacted by this issue of substance use disorders in our state in two very significant ways. In 2006, I had a family member who was sadly the victim of violent crime in the course of a robbery conducted by an individual who was under the controlled use of substances. And as a result of that robbery, she passed away. And he is now serving 2 life sentences as a result of that murder. And so we've had a loss of life in the family. In addition to that, my husband and I had a son, an adopted son that we were guardians of when we were first married, a wonderful young man that we took in who was going to go into the foster system. We became his guardians at the age of 13, saw him through college and through his early working years. And he got into an accident at work, became dependent upon opioid pain medicine, and later, to shorten up a long story, died of a drug overdose due to illicit drug use that stemmed from his opioid addiction. And so we have been impacted by this deeply personally, losing 2 family members through 2 different aspects of this issue. And so when various stakeholders approached me about a bill to take a look at a statewide coordinated response to these issues so that we don't have to have any family members or individuals who have experienced the impacts that we've experienced and that we've seen across our state as a result of this epidemic. We realized that there was a need for coordinating all the efforts across the state. I know that many of you on this in this committee have given your life purpose to this cause and are doing amazing things. What we wanted to do was to make sure that we were all coming together and ensuring that we weren't duplicating our efforts, that we were taking the best practices among us within the state and also models from around the United States to have the best coordinated response to help to prevent individuals from substance use disorders and from the impacts of it, also to help increase the best access to treatment and the best programs available, and then also to deal in a coordinated effort to respond so that we can ensure that we are addressing some of the other impacts of substance use disorders in our state, such as the impacts on our criminal justice system, making sure that we're responding appropriately, impacts on housing, on families, on education, on our communities as a whole. And so the purpose of this group is to really come together to help coordinate, to help provide a statewide vision and plan based on best practices to prevent, to treat, and to respond. And the ideal end goal, my husband asked me this morning as I was getting ready, what's the end result of this? The end result of this is that hopefully year after year, we see the impacts of this group on less overdoses, less crime, less domestic violence, less impacts on families and our communities and schools, less families that have a story like ours. Less families that have stories like yours that I know many of you have as you come to this work. So when I say it's an honor, that's not just political lip service. This genuinely is something that I will always look back on as one of the most meaningful things that I was able to be a part of. And I'm just honored to be here with all of you and to learn from all of you and to work alongside and to help in every way that I can. And so I hope that helps explain, Stephanie, my legislative intent for what I bring to this and what I hope out of it. I do have some suggestions as we get to items 7 and 8 in regards to ways that we can break out this work to ensure that we meet those benchmarks. But I also am very much looking forward to hearing from all of you as you share your inputs on what we determine as success for this group in at the end of the day, people's lives. Thank you.
Assemblywoman Toles, thank you so much for your willingness to show your vulnerability and your sincerity regarding this topic. I've worked with Assemblywoman Toles for years, both in the legislature and in my capacity as Attorney General. I've always known her to be a sincere advocate for what she's doing, reasonable, and someone who's dedicated to the community. We're going to miss you in the legislature, but I'm so glad that we have you with us on this committee, because with your assistance and co-chairing this with me, I'm certain that we will be able to make some momentous gains in this fight against substance use and misuse. So thank you again for first of all sponsoring the legislation, I guess I should say, that created this, but then also your dedication to this topic. Let me now give the mic back to Dr. Woodard, and you can continue on agenda item number 4.
Thank you. And again, thank you, Assemblywoman Toles, for the introduction in helping to orient everyone on this group into the intent for putting this important piece of legislation together. So as I mentioned before, the Department of Health and Human Services wants to be successful in bringing forward the information as required through this legislation. And as we discussed internally within DHHS, how we might be able to get to this, what became very clear was that while this section of the legislation is incredibly short, it could be very far reaching. And there may be some limitations for our ability to fully satisfy this section without really understanding from the group how we can best make sure that we are meeting the requirements of the legislation. So certainly the first 2 items, specific detailed information related to the settlement funding that comes into the state as a result of the opioid litigation, as well as the funding that comes in through any judgment. Those 2 items are very clear. The other 2 that relate to grants, gifts and donations to the state and political subdivisions. Certainly within DHHS, we can capture all of the grants that have to do with substance misuse, but may have a little bit more of a challenge in gathering some of that information from political subdivisions. So wanted to open it up to the group to better understand any ideas that this group may have on sort of where the depth and breadth of the information provided to this group would be most appropriate and sufficient.
Okay, mic's open. I think I see Ms. Nadler trying to jump on.
Hi, this is Debbie Nadler. Thank y'all for everything you're doing. Could we get a copy of the bill that you're talking about, or do we have a copy?
We can, I'm sorry, go ahead, Dr. Wood.
We can certainly provide that. I believe it was also provided at the first meeting.
I'm sorry, I just moved, so I apologize. I probably have it in my notes. But I just wanted to make sure that we did. And your question was, do we have any ideas or suggestions for that? Did I misunderstand?
Yes, that's correct. Thank you, Debbie Stephanie Woodard, for the record. Really hoping to have a bit of a conversation today around what this committee would be expecting by way of a report from DHHS to capture the information that's required in the legislation. So really hoping to generate some ideas.
Thank you.
Okay, we have someone down here. Go ahead, ma'am, Mike Shores, and please introduce yourself for the record.
Hi, Jessica Johnson for the record. I want to say that perhaps the information is on page 7 in the packet that was distributed today for the legislation. Dr. Woodard, would you mind just, I know you went through really clearly when you were talking and I was trying to orient myself to the specific area. Would you mind Just restating, was that specifically part of Article 3 when you were mentioning kind of the first couple of items, or maybe Lisa's more clear on that? Thank you.
Stephanie Woodard for the record. Let me locate it again because I just actually closed it. But I see Chair Lisa Lee has her hand up as well.
Yeah, why don't we go ahead and I'll also say this, whoever's running the Zoom, if we can get a copy of the link to the bill, we can put it in the chat. So if someone knows how to do that, please do that. And or maybe Ms. Toles, maybe if you have access to Nellis, maybe you can put a copy of the bill, a link to it in the chat. With that, Ms. Lee, go ahead.
Lisa Lee for the record. Which packet are you referring to, Jessica? I don't think virtual attendees have received any packet. I'm looking at the items that we received.
It's the annual report of the statewide substance use response working group, which I had sent out to all of you. And if you look under the bylaws, it's page 7 under the bylaws, and it's Article 2, creation and purpose, Section 1, creation. And about midway through that, it says the Nevada Department of Health and Human Services is required to annually report to the working group concerning the use of state and local money to address substance misuse and substance use disorders.
Got it.
Which
I'm
that was
actually on that
pulled from
page. Thank you.
Okay, yeah, and that was pulled right out of AB 374, the verbiage right out of the bill.
Thank you so much. There is a grammatical error at the bottom, the last sentence of that paragraph.
You see it?
What's the?
The harms
Lisa,
of
what's the-
substances abuses.
Oh, okay. Harms of substance abuses. Okay, thank you. I got it.
Dr. Woodard, I will say this draft that you have submitted is quite good, frankly, relative to the types of things I would think we need to be including in this report, this initial report. I can provide a couple of updates to the Nevada opioid litigation. It's numbered page 7 in my packet here, and I think it's a little different for other people, but it says update on Nevada's opioid litigation, and you talk about documents available and the process notes and next steps, Dr. Woodard. Maybe we should include the fact that we've already received $45 million in the settlement from McKinsey and Company. We got that back in March. I believe I announced it in March. And then on January 3rd, I think it was, of this year, I announced that we're going to be receiving $285 million additional in opioid settlement money from distributors and one manufacturer of opioids. Johnson & Johnson is going to be giving approximately 60 million, which is a little, that's a round up, if you will, but we'll be getting the vast 95% of that this year. And we will be getting additional monies, probably around 35 million, if I remember correctly. Don't quote me, but we can get you numbers on that from the additional settlement that we announced with 3 distributors as well. So I would think that we should put that into this report. I'm happy to touch base with you offline. And we also received a grant. Dr. Kearns has been able to secure monies for us as well. So I think that type of information should likewise be included, and maybe Terry can coordinate with you offline to update that component or that portion of this report with those actual numbers. Does that make sense?
Yes.
Okay.
Yes, and thank you, Attorney General Ford. Stephanie Woodard for the record. And for those who are attempting to locate the section in the actual bill, it's section 10.5.
Thank you. And
So
Stephanie,
Dr. Woodard, I'm sorry, go ahead, Assemblywoman Toles, go ahead, I'm sorry.
thank you, Assemblywoman Toles, for the record. If we could also put the link to the packet so that everyone could be looking at the same thing in chat, I think that might be helpful, because for those who are attending virtually and for those who are watching in the public online, just to see where that site is with all the agenda items. so that we can make sure that everybody is looking, when we refer to page 7, everyone's looking at the same thing, whether they're viewing in the public, virtually, or in the room. That would be helpful. Thank you.
Ms. Hale?
Thank you, Mr. Attorney General. I just wanted people to know that we had blocked the chat because of the open meeting law. And so we just need to make sure that within the chat system that there's nothing that is something that would be affected by the open meeting law. We turned it back on to try to respond, but just want to make sure that people know that.
Very good. Thank you. I am so happy you mentioned that. Do I have my my DAG on the line?
Yeah, Hannah is covering. Yeah, Hannah's covering for Rosalie.
Okay, Hannah, can you be certain that we aren't messing this thing up right now? Hannah, are you there?
I'm here. Can you hear me?
Yes, go ahead.
You're fine so long as the chat's recorded in the minutes.
Okay, yeah, because the only thing that should be in the chat so far, and I can't see the chat, is a link to the bill, which is public information and available for everybody, and then a link to the packet that we're looking at here in the meeting, which is likewise public. So I will ask that we refrain from utilizing the chat at this point because I don't want to get us in trouble. How about that?
Yeah, and just so thus far, as long as it's recorded in the minutes, or you're fine, or transcribed, but it can be turned off at this point as well.
Thank you so much. Why don't we go ahead and turn it off? And if we need to distribute something else, we'll turn it back on and make it a point to mention it in the minutes.
Thank you. And Chair, if I could just request that for people watching on the public or anyone else, so that they see what was linked in the chat, if you could just walk us through where we would go on the AG's website. I see that it's under About and then Administration, but walk people through so that they can link to that public site as well. I know for those who are used to chiming in on public meetings, it may be really easy to find and to access, but for the general public, I think it's also extremely important, since accessibility is a huge part of this working group, to make sure that we know how to navigate to that page. So if somebody could speak to that, that would be helpful. So that it's not just those of us who have the link in Zoom, but we have it on record where the general public can find this information on your website.
Sure. So this is Terry Kearns for the record. It is on the agenda, the 2 links at the bottom of the page under adjournment, and it's online at the https://notice.nv.gov/ and then it's on the Attorney General's site. If you go to the Nevada Attorney General's office, go to About tab at the top of the page, and then there will be a drop-down menu. Go to Administration, and then under Administration, there's a Substance Use Response Working Group, SURG, and the agenda and all items are posted in both spots. Thank you.
Okay.
Thank you, Terry. And I'm so sorry, Chair, to belabor this, but as I look at the website, I don't see an administration link on the drop-down menu. And so I think that might be what may be causing some confusion for folks. There's the About tab, but we can, there's the About tab, and there's the Nevada Attorney General Bureau of Consumer Protection. And maybe I'm just missing it, but I just want to make sure that we have that drop down accessible.
Okay, well, appreciate that. We're gonna look into that and circle back to it, okay, so moment toes. I'd like to continue the conversation on this particular matter. I see Ms. Lee has her hand up, and then I want to circle back to Dr. Woodard. Go ahead, Ms. Lee.
Lisa Lee, for the record, I did post the direct link in the chat, which goes straight, it's the one that Dr. Kearns referenced on the agenda. It goes straight to all documents related to this group, this body substance use response working group, including the agenda and attachments.
Great. Thank you. Okay, so I want to be certain that we understand our task on this agenda item. Dr. Woodard, you were asking if there were, I interpret what you're asking. Is there anything additional to what you've already suggested relative to this draft that we should include in this report? Is that right?
So thank you, Attorney General Stephanie Woodard, for the record. So this agenda item 4, is separate from the review for and feedback for the draft annual report that is on 6. So I understand that you would like some information in that report updated. But the goal of this agenda item really was to have a discussion from this group to better understand what the expectations were of this group for DHHS to be able to satisfy this section of the bill. So in section 10.5 of Assembly Bill 374, we have a requirement to submit to the working group annually a report concerning the use of a number of different funds, including grants, gifts, and donations received by the state and each political subdivision of the state for purposes related to substance misuse and substance use disorders, as well as all other money spent by the state and each political subdivision of the state for purposes related to substance misuse and substance use disorders. When we were reviewing this internally to really start to build a format of how we would be able to gather the necessary information to satisfy this section of the legislation, what became very clear very quickly was that we were going to need to make standardized requests to each political subdivision for information that they would be able to provide to us that we could then include in the annual report. In addition to that, we were contemplating also gathering this information from other state divisions and departments, such as the Department of Corrections, our state Medicaid agency, and the like. You can imagine that there may also be dollars that are spent by each political subdivision in doing things like providing services and supports for individuals or families impacted by substance use that are also involved in the child welfare system. And so really, as we were sort of brainstorming what this could include, we felt that it was best to bring this to the committee for a conversation so that we could at least begin the discussion around what information would reasonably be expected to be included in this report.
Okay. All right. We've heard the question. Any responses to that? I will offer 2 right now. You touched on it. I'd be interested in understanding the money spent for the foster care system to ensure that those children who've been affected and are in the foster care system are being assisted with funds coming into the state and to the municipalities. I'd also be interested in what we're doing in the jails around this issue and how the monies are being utilized at the state level in our corrections system to ensure that we're getting people help where we're needed in that regard. Those are 2 suggestions that I have. Before I go to Ms. Lee, let me see if there's anybody down here. Assemblywoman?
Yes, sir.
Claire Thomas.
For the record, Assemblywoman Claire Thomas. I was concerned about veterans because we know that our veterans have a high rate of opiate use and drug use.
Okay. Veterans, in case you didn't hear, how we're utilizing our monies to assist them. Ms. Lee, and then Ms. Nadler.
Lisa Lee for the record. In addition to children placed in out-of-home care, I would be interested in seeing more family-centered treatment options and families that have preserved in-home care due to monies expended. And then also just thinking about racial justice and how communities of color have been disproportionately affected by the war on drugs. I would be interested in also receiving reports with that racial justice lens, just looking at how communities are impacted across our state and looking at public health equity. Thank you.
Great points, Ms. Lee. The demographic information that you've requested, I think is absolutely apropos. And so thanks for reminding us of that as well. I see Ms. Nadler's hand is up, but let me be clear though. So Dr. Wood, are you able to hear all of this? Okay.
Yes, thank you.
Very good. Okay, I see Ms. Nadler, and then down here, I have a couple of responses. Go ahead, Ms. Nadler.
Hi, Debbie Nadler for the record. I'd be interested to see, and I apologize, I've got one computer I'm working off of. I'd be interested to see where the money is being spent for education in the school systems in mental health and counselors, if we're going to be doing anything. I know Governor Sisolak passed a bill that mandated mental health into the school system, which included some kind of substance use. So I would be interested, especially in the schools, where the money is going. That's first. Second, I'd be interested to see where it's going for on-demand treatment services here in our state. I've worked with a lot of kids and they have nowhere to go. We don't have an on-demand treatment service here. And thirdly, information on Medicaid. There's 4 levels from my understanding of Medicaid. A lot of each Medicaid is different, and each detox center, rehab, et cetera, it's not defined on what is allowed for them to get services. So I guess really the education and on-demand treatment, and then Medicaid for those who need it.
Thank you, Ms. Nadler. Let's come down south here. Yes, ma'am. Yeah, doctor, go ahead.
No.
You're good? Okay.
Hi, Jessica Johnson for the record. Dr. Woodard, I have sort of a clarifying question to what you mentioned. I apologize for belaboring this. I want to make sure I'm really understanding. So in section 10.5, what I heard you say was that 1 and 2, the DHHS had already felt like they had mechanisms to report on. But number 3 and 4, so around the any gifts, grants, or donations, and then specifically the other money spent, that was where you were hoping for some direction. Okay, I've seen you nod your head on video. Okay. One thought that I had sort of listening to the conversation today for consideration might be when it comes to number 4, perhaps we could consider, I'm going to mess up the section, but section 10(2)(b), where it talks about special populations includes without limitation. On our packet, it's page 8, letter C, letters A through G, lowercase letters A through G. So that mentions veterans, elderly persons, youth. So I'm wondering if maybe if we could consider these special populations that have been outlined within this work as a way to offer some streamlining around sections 3 or section 10.5, sections 3 and 4. In listening to folks today, I know Lisa mentioned BIPOC communities of color as maybe other populations disproportionately impacted. But I was wondering if the group, if there was some agreement around the ones that were listed here, and if there were any, as a place to start, I guess, in terms of thinking through how to narrow down these kind of the broad language within section 10.5, 3 and 4 around the gifts, grants, donations, and then other money spent. Thank you.
Thanks so much. Zoom Thomas, did you have something else to say?
No, that was it.
Okay.
We have Christine Payson online who would like to make a comment.
Say that again.
Christine Payson.
Ms. Payson, I understand you would like to make a comment.
Good morning. Thank you. Can you hear me okay?
We can.
Hi, Christine Payson for the record. And I hope I'm mentioning this in the right time frame, but one of the things that we're looking at from a law enforcement perspective is holding those responsible that are bringing this poison into our streets and holding them responsible for the cause of death and identifying that source of supply that results in an overdose death. And what we're trying to do is identify funding for an independent medical examiner report that verifies the cause of death. The DA is requiring this report at the time of a case submittal, and the cost for that report is quite significant. So we're trying to find out ways to identify a source of fundings to get those reports so we can get it to the DA when the case is submitted. And like I said, ultimately hold those responsible who brought that poison in. So it's just putting that out there.
I appreciate that, Ms. Payson. We should think through where that fits in the conversation. I think a discussion around whether monies that are received through settlements or judgments on this can be allocated to such a program is a separate conversation. I'm not certain. I appreciate you bringing it up though, because we should take note of that and be sure to circle back to it. I'm not certain that it fits right here what Dr. Woodard is looking for, but that's a very good point to bring up, and we will put a pin in it and circle back. And I know that my people won't let me forget, so we'll be back to that.
We have Eric in Carson City.
I have Eric in Carson City, please. Go ahead. Eric, you're on mute, I believe.
Can you hear me now?
Yes.
We can. Yes, sir. Go ahead.
All right. Thank you, Chairman Ford. I think I heard I don't mean to repeat this, but I think I heard somebody say in Las Vegas, overlaying our priorities, our committee's priorities with the different funding streams that come through as a way of trying to provide some order. I mean, these are all wonderful suggestions and great ideas. But maybe one organizing principle is to overlay the funding streams with the different priorities that we've identified as a committee, whether by population or other organizing principle. That might be one way to provide the information in a coherent way.
Yeah, I like that. And I'm going to say this. I know Dr. Woodard is a professional 100%, and she's receiving our information, and she's going to utilize her discretion to organize it, probably as you've indicated. Plus in other digestible ways as well. So thanks for suggesting that. Other suggestions for Dr. Woodard on this matter? I don't want to belabor it. If we don't have much more, we can move on to other agenda items. Dr. Woodard, do you have enough for now?
I think it's on.
Stephanie Woodard for the record. Yes, thank you, Attorney General Ford. What I would like to do is pull together the recommendations of this group and develop really just kind of a skeleton or draft outline of what this report could potentially include, and populate it with existing information that we already have available, such as the information that you had also mentioned previously related to some of the settlement funds that we know are already coming in, to bring back to this group at another meeting to make sure that we are going in the right direction.
Perfect. Okay. Appended to agenda item 4 is also a review of initial findings and provide feedback for the statewide needs assessment for the Advisory Committee for Resilient Nevada. I don't know if is that a different agenda item, or is it still part of 4? It is part of 4. Do you see what I'm saying here? Is that on yours? Okay, all right. I have a bad copy. My apologies, y'all. I had a presentation from Courtney Cantrell and Kathy.
That's 5.
That is 5. Well, my stuff is all out of order here. Let me look at another copy here. Sorry, y'all.
Mine reflects the same as yours.
It does, huh? We just did 4. Number 5. Okay. All right, we'll move on to. All right, yeah, this is wrong. All right, I'll look at number 5 on this new agenda here, Review initial findings and provide feedback for the statewide needs assessment for the Advisory Committee for Resilient Nevada, agenda item number 5. Let me tender the mic to Courtney Cantrell, Dr. Cantrell, pardon me, Kathy Nichols, and Jordan Bublik.
Hi, thank you, Attorney General Ford and the SURG work group. We're really excited to be here today. We all work with Mercer Government Services, who the state has contracted with to do your needs assessment. So what we wanted to present today is our initial findings for the first round of documents that we reviewed. We've reviewed hundreds of pages of reports for the state of Nevada. to help contribute to the understanding of opioids. So today, if you could go to the next slide, please. As far as the agenda for this particular presentation goes, we're going to go over the background and methodology of what we're doing and what we're collecting. We're going to go over the opioid impact as far as we know it so far. We're also going to talk through some of the risk factors, both system-wide and individual risk factors in Nevada when it comes to the opioid issues. We're going to talk a little bit about polysubstance co-occurring conditions and suicide impact, as well as some current and potential resources and programs that we know are going on in your state right now. And then finally, we'll talk a little bit about next steps, future directions, and open for questions if it's all right with you. We are here to take some feedback on any additional information or anything we seem to not be emphasizing enough or not quite have right. But I will caveat that with, this is not the actual needs assessment. This is the first bit that we've read. It's the first round of identifying some of the biggest pieces of impact for opioids that are going to go into the needs assessment. So we have more to come and more presentations in the future, but for now, we just wanted to give you guys a start of understanding what it is that we're looking at, what we're seeing out there, and we look forward to hearing from you as well. So, okay, next slide. So for the background and methodology, next slide, please. First, we wanted to talk a little bit about Nevada's substance use history and what it's looked like over time. So from 2011 to 2015, opioid overdoses and prescribing rates were on the rise as they were nationwide. In 2015, Nevada had the second highest prescribing rates of hydrocodone and oxycodone in the United States. Then the Obama administration declared the opioid epidemic a national emergency. So around late 2015 and early 2016, they began efforts to start combating the crisis and putting funding into things. With that federal funding, Nevada began to work with and address the crisis by holding a statewide opioid conference and developing legislation to curb prescribing. In 2017, Nevada implemented the Drug Enforcement Administration's High Intensity Drug Trafficking Area Program, which is called HIDTA, to determine the critical drug trafficking areas within the state. And then in 2018, the rates of methamphetamines and fentanyl have started to drastically increase. And by 2019, Nevada saw the opioid overdose deaths with stimulants as a contributing factor to that increase. So that brings us closer to present. Of course, the pandemic happened. Up to this point, historically across the country, opioid rates between 2015 and 2018 had actually decreased some. Some of the efforts that states were making were really starting to pay off. And then the pandemic hit. And as you know, everything just kind of blew up. So in 2020, Nevada is not alone in having experienced an increase and a sharp increase in polysubstance overdoses, as well as illicit pill consumption. So this all brings us to where we are today. And next slide, please. So this is a very busy slide. It's just to kind of show you and as a reference for the kind of information that we've been reviewing that goes into the needs assessment so far. So Senate Bill 390 established the Fund for a Resilient Nevada within DHHS. And per that legislation, a statewide needs assessment to determine how to create a state plan to combat the opioid epidemic. It also asks us to set priorities for funding, well, asks us to help you set priorities for funding the needs in that state plan. It also says that the needs assessment must use qualitative and quantitative data and evidence-based practices in order to develop that needs assessment. So we have reviewed applicable legislation, a number of seminal documents that you see on the right-hand side, and sometimes within those documents, there are several reports within each one. So like hundreds of pages thus far, and there's still more to come that we have to look at, as well as key data sources. And we've also received input from other state agencies as well through Dr. Woodard's group. So next slide, please. So that's our background and methodology that we're using. And so next is the opioid impact. Again, this is not going to be representative of everything going on with opioids in Nevada. This is just some highlights of what we've identified. So next slide. Despite tremendous improvement, Nevada ranked 28th in the opioid overdose deaths and 20th in opioid prescribing in 2019. In 2020, the US saw a 30% increase in opioid-related overdose deaths, and nationwide, while Nevada was not spared from that sharp increase. From 2019 to 2020, opioid-related overdose deaths increased by 76% in your state. There was also an increase in fentanyl use and opioid-related emergency department encounters by 227% for fentanyl use and 26% for emergency department visits. The subpopulations within Nevada have also experienced increases in opioid use. Self-reported use of heroin and other opioids among pregnant women in particular has quadrupled, and neonatal opioid exposure has doubled. So you guys have some potential future problems brewing as all this neonatal exposure and more pregnant women are using heroin and other opioids. So, next slide, please. All right. This is kind of busy, but there's so much data out there on the opioids and we only have so much time. So we decided to take the top 3 risk factors for opioid overdose in all these different categories just to kind of show you what the top 3 statistics are. So for instance, when it comes to age, the people who have a risk for the highest risk for overdose are those that are 55 to 64. And then below that is people 45 to 54, and below that is people 25 to 34 with the associated rates next to each one. So that's how you read this, this slide. There's a lot there, but it's more for your reference. Our report will have more graphs and things like that that have more data in them. So in 2020, the overdose deaths in Nevada of all types increased 55%, with 65% of all overdose deaths involving opioids. Opioid-related overdoses in Nevada mostly occurred in white men, again, ages 45 to 64, with a high school diploma, and who had either a current substance use disorder, and in most cases, they occurred at home with a bystander present. Fentanyl was the top opioid contributor, and ingestion was the primary route. And opioids were also combined with stimulants such as methamphetamines 26% of the time. And in Clark and Washoe County, those were the top 2 counties with numbers of overdoses. Of course, those are your biggest counties, so that would follow. That would make sense. Next slide, please. All right, so from 2019 to 2020, Nevada's northern and southern regions, and we're talking about behavioral health regions, not kind of how you talk about the different parts of the state every day, but they're behavioral health regions in the north and south, experienced a similar percentage of overdose deaths due to opioids, despite Southern Nevada's almost triple number of overdose deaths. So that's, again, the difference between a percentage and a number. Of course, a percentage is going to look really big when you have a small population, and a number is going to sometimes look really big compared to, there's only so many people in a region of the state. So we have to look at both because every life does matter. Well, Northern Nevada saw a 164% increase in deaths due to opioids. Southern Nevada saw a 257% increase. When you look at the county level data, Churchill, Lyon, Humboldt, Lincoln, and Carson City were the top 5 counties with the highest rates of opioid related overdose deaths. Of those 5 counties, Lincoln County is the only one that's located in Southern Nevada. The other 4 counties are located in Northern Nevada, indicating that while Southern Nevada is experiencing a higher count of opioid-related overdose deaths, the overdose deaths are occurring at a higher rate in Northern Nevada relative to the population. And the next slide, please. Health equity and disparities are very important to look at, although I will say the data so far is a little sparse around really seeing who is not being served. So when it comes to health equity, Nevada, of course, has a high population of minorities, with about 1/3 of the population speaking a language other than English at home. Nevada also has the highest percentage of uninsured, unauthorized immigrants in the Western region. Your state also has a number of federally recognized tribes, with 97% of the tribal population living in rural areas and 30% living in poverty. And we say a lot of this because when it comes to people who tend to be underserved and tend to experience the largest health disparities, it is people who are immigrants, who are uninsured. It is people of color, and in particular, Native Americans as well. So we're kind of trying to come at it from the side, since we don't have a lot of direct data that we've seen yet. We still have more to look at that really addresses some of the disparities in treatment or in risk. So Nevada is also very low in the number of substance use providers per 1,000 adults for addictions when compared to the national average. And when it comes to your state, Hispanics are also facing a much higher rate of overdose deaths when compared to other ethnicities. Again, that's the rate within that population. The rate increased 120% from 2019 to 2020 that we know of. The next slide, please. Due to your unique location, as you know, Nevada is a prime target for drug trafficking. It's near Arizona and California, and the largest expanse of interstate through the frontier and rural areas really presents a unique challenge to law enforcement in order to be able to track drug transportation and other illicit activity. In addition, of course, Las Vegas presents a unique challenge for gaming, money laundering, and drug trafficking as well. Next slide. All right, so next we're going to touch on some of the risk factors we've found in the reports that we've read so far. So next slide, we're going to start with the system level risk factors. So we've kind of categorized some of the different system level risk factors. These are risk factors for having increased opioid overdoses across your system or increased hospitalizations across your system. So prevention programming. So if you don't have great prevention programming, you're going to see more problems as a system. So there's been identified a lack of unified statewide prevention programming that has established outcomes that are measured. When you do have outcomes that are measured in smaller programs, it's easier to fund them and to increase them across the state and really see some big differences. And right now you've got some great pilot programs going on and small programs that are funded, but there lacks a big unified method of prevention across the state. There's also drug education and school-based interventions. Again, the same way, great pockets going on, but there's not a unified method of getting that programming statewide. So harm reduction is another very important aspect, of course, of combating the opioid problem. That would be needle exchanges. We know that you have some really innovative things like dispensers that people can, I can't think of the word, put money in and get the needle exchanges. So that's really exciting that you're doing that. It makes it a lot more accessible to people to at least decrease the harm and decrease some hepatitis C and other things that are negative impacts of the drug use. But there's more that needs to be done. And there's recovery support. So that comes down to more of a, once there is a problem, there's recovery support is needed. Parent education, employment support, housing, things like that, and transportation I'll talk about in a minute, are all very important that once people have had treatment or are moving towards recovery, they really need that support in their lives. If they're parents, they need some parent education on how to reevaluate now, how to parent their kids now that they may be more engaged and better functioning. Access to treatment is the final system level risk factor. It's really important, of course, to have access to treatment for people. You can't have access to treatment without transportation. When people don't have housing, treatment's not the highest priority for them, as I'm sure you already know. A lack of providers in your state is a definite barrier. There is a lack of referrals as well. We know people have substance use disorders, but they don't seem to either be getting screened or they don't have the knowledge of where to go to get help, or that they can get help given whatever funding source they may be tied to. There's also, of course, stigma and again, a lack of education regarding the treatment options. And there's a need for a little bit more data to monitor quality, access, and capacity across your treatment system to really get an idea of where the access needs are. Okay, next slide. And then there are individual level risk factors. We just threw a few of them up here that we've found. I don't think any are unique for Nevada. Everything is pretty much kind of known what those opioid risk factors are for individuals. But one of the biggest and most important ones does seem to be the adverse child experiences, the ACEs. So that's the one that I think it's on the third column there. But basically, when kids experience trauma when they're younger, that really increases the probability that they're going to end up using substances as adults or as adolescents and children. So that's one place that we are going to have a lot more expansive in the report, is talking about those ACEs and how to, not how to, but in some impacts that it's having on risk for individual substance use. And next slide, please. Okay, so a vulnerability assessment was conducted by DHHS in 2019 to evaluate the risk of opioid overdose and HIV in Nevada's counties. The counties were assessed on criteria that were based on the socioeconomic indicators like income, poverty level, education, transportation, and employment. They looked at infectious disease indicators focused on HIV, hepatitis B and C, and sexually transmitted infections, as well as drug use indicators that focused on ED and inpatient admission rates for opioid and methamphetamine related visits. They looked at opioid prescription rates, as well as opioid and methamphetamine related deaths. So those a lot of times will go together. That vulnerability assessment found that Nye, Lyon, Story, Mineral, Washoe, and Carson City counties were the most vulnerable. As we learned on a previous slide, Nye and Washoe were among the top 5 counties with the highest number of suspected opioid overdose deaths. And Lyon and Carson City were among the top 5 counties with that highest rate of opioid-related deaths. So this is just one vulnerability assessment. There are several other really interesting, like a CAST tool is one that looked at the risk in each county and region of opioid hospitalizations. There are a lot of interesting things out there that we'll include in the report, but for now, this was probably one of the more interesting ones, and it was somewhat consistent with the with at least one of the others that I looked at. So next slide, please. Okay, so now we'll talk a little bit about polysubstance co-occurring and suicide impact, because opioids are absolutely often used with other substances. They're often used to alleviate other disorders, be they behavioral or for physical, and they're also often associated with suicide impact. People can get very tired of having a substance use disorder or an addiction, and it can really impact your suicide rates. Next slide, please. All right, so on that graph, the most important thing is that the opioid is the solid blue or the blue line, and heroin is the orange line. So, and you see a little ICD thing on there, that just has to do with diagnostic terminology. Diagnostic terminology changed between 2015 and 2016. So they just have to mark that some of the criteria were different to have an opioid use disorder or a cocaine use disorder, things like that. So you can kind of ignore that, but know that it might have impacted the number after that point in the graph. But while there is a lack of sufficient treatment for OUD, hallucinogens combined with marijuana and methamphetamines are also an increasing problem in the state, as you can see from that graph. The intervention efforts that are put forward do need to address polysubstance concerns and not just opioid use, because it's often not the only thing that's used. Next slide, please. As I mentioned, co-occurring conditions. So both physical and behavioral health conditions can conflate the issues of opioid overdose and death. Mental illness, especially suicide, represents a concern across populations from adolescents to veterans, populations also at high risk for OUD. In addition, risky behaviors like unprotected sex or needle sharing also leads to issues like STDs and other communicable diseases, as well as other conditions like COVID and other bacterial and fungal infections that we found among people who use and share those needles. So of course, when it comes to behavioral health, people may have a lot of anxiety and trauma and things growing up, and an opioid use disorder can come out of that because they've started to self-medicate with an opioid. That can happen. Lots of that kind of stuff can happen. And then when it comes to the physical health side, often it would be the opioid use disorder that comes first, and then that influences people potentially contracting HIV, AIDS, hepatitis, things like that. Next slide, please. So now we're to the current and political resources and resources and programs through your state. So next slide, the first thing that we were looking at that you already have is that you of course have medication assisted treatment, which is wonderful. You have 648 providers doing what we call OBOT. That would be a physician who has a waiver from the federal government, from the DEA, the Drug Enforcement Agency, to prescribe buprenorphine, something that your primary care doc normally can't do unless they have this waiver. So ideally, somebody could go to any doctor that's willing to prescribe buprenorphine and has the waiver and get opioid use disorder treatment. But of the 648 providers, they're only in 10 counties. You also have, and they're often not prescribing up to the capacity that they're allowed to for a number of different reasons. You also have some OTPs, which are opioid treatment programs. Those are kind of state certified, and they have some links to the federal government oversight to make, and that's where methadone and other treatment is often done. So when you have OTPs, you usually have some kind of psychosocial treatment as well, not just the medication. There are 15 of those in Clark and Washoe counties, as well as Carson City, and most have some capacity. So there's an indication there that there needs to be more referral and identification. And then there are also opportunities that we've identified from the reading we've done so far, which is, one is reimbursement rates. And we know there are efforts right now to do some P-code, which is a different model of reimbursing these organizations and the people that provide this treatment to make it more sustainable. We also think there are opportunities for increased referrals and then increased counseling, because I mentioned the OBOT providers, which are your docs, who are your regular physicians that are just going to, that can do buprenorphine in their offices, they don't always have the capacity or the ability to do counseling as well, which is a best practice. And so we want to increase the amount of counseling that goes along with that medication treatment, because it's got to be medication assisted, not just medication treatment. And people are definitely trying to do that. So, excuse me. So the next one, housing and employment. Housing and employment are incredibly important. We know that social determinants of health have been more and more recognized as a factor in assisting in recovery-oriented systems of care. And there is just not enough sober housing available in the state, although the state leaders have been working with Oxford House on developing a certification program for recovery housing, and funds are being used to build the infrastructure, but more services are definitely needed, or more resources are needed for housing the population of people who are trying to experience substance use recovery, getting treatment and trying to get out there. But if they don't have housing, it's not going to stick in a way. So next slide. Okay, so criminal justice. SOAR funds, which are the state opioid response funds, are being used to address polysubstance use. At first, I believe they came out, they could only be opioid, but they were expanded to address polysubstance, which is wonderful because, as you saw in the graph earlier, things like methamphetamines are on an increase. They don't have to just provide stabilization. They can do things other than treatment, like housing and wraparound services. Naloxone, which is the rescue drug used for overdoses for opioids, also continues to be a state priority, as well as a Johns Hopkins recommendation, which means it's a best practice for the state. The next slide. We also found that harm reduction needs to go hand in hand with the treatment as part of addressing the opioid epidemic. So some of the current efforts in Nevada as making towards harm reduction are noted in the graphic. Again, you guys evaluated supervised consumption spaces, established and evaluated supervised consumption spaces, having needle and syringe exchange programs, disseminating the value and use of test kits for fentanyl-laced opioids, which has been increasingly important recently. And then finally, CDC money is being used to implement a needle exchange shipping program with 75% county participation. But I'll say that some of our information might be a little old. I've heard that maybe that was discontinued, but that's one of the things that we found that we'll talk a little bit more about in the report. So next slide, please. And workforce shortages. Now this is a big area. So there's a whole giant report that we read on workforce shortages. And so we only have one slide on it, but understand that we will probably put a little bit more time in the report on it, because it's a big deal. If you don't have people to support people in their recovery and treatment and prevention, then it's going to really be hard to accomplish the goals. So there are different regions of the state that have different workforce strategies that are identified. There is some overlap in that. But the shortages range from independent practitioners and psychiatrists specializing in substance use to short and long-term residential services, as well as detox services. So depending on where you are, you have different shortages. There's also a certification training program for community health workers that can be utilized to connect members with their services and community resources. Also, more peer support is often needed, because people who are in recovery and people who are maybe moving towards treatment really benefit from talking with people and working with people who have lived experience in what they're dealing with. So next slide, please. Prevention and recovery. Prevention efforts need to include both suicide programming as well as increased access to those social determinants of health resources like transportation and housing. Nevada really needs a true recovery-oriented system of care as well, allowing individuals to have that transportation to attend treatment, but also to have resources in the community that help them to stay stable, like tenancy supports and reducing stigma towards opioid users, as well as reducing stigma towards recovery, and then increasing that community support that's available. So these are just some of the initial findings, or additional findings. And next. We also are just highlighted two here, even though we know there are a lot more local interventions that really could be expanded to the rest of the state once the data is collected and evaluated. One of those is mobile outreach safety teams. It's when you have a BH provider or behavioral health provider with law enforcement that visit people together in the community that are at risk of incarceration. So that's really an assertive outreach to people that they know are at risk for bad things to happen in the future, as well as the forensic assessment services triage teams, which are multidisciplinary teams that collaborate between clinicians and law enforcement to screen inmates for opioid use disorders. And you've also got, I think, some drug courts as well that try and get people into treatment rather than incarceration. So there's a lot of things that Nevada is doing that could be capitalized upon. It's just not everywhere again. The next slide. And then parenting as a path to recovery. So as we mentioned earlier, use among pregnant women and neonatal exposure has been increasing. And there's currently a lack of a unified neonatal program in the state. The two entities above are listed on there have created some specialized diagnostic and treatment services to address the issues. And that could be replicated to have more than one resource. Now, I'll also say that as the ASTO Omni program, it's the Association of State and Territorial, okay, I can't remember the rest of what ASTO stands for, but it's a public health entity, has created a program that Nevada has really created and taken ownership of, where you're creating toolkits for people taking care of children with neonatal abstinence syndrome. Also other education efforts. So there are things going on, but again, probably could be used in a broader sense and disseminated more if there were more funds put towards it. Okay, next slide. There we go. So the Johns Hopkins Bloomberg School of Public Health has come out with a bunch of recommendations, and the state has really been working towards each one of those that you see on the screen. Those recommendations are what they found to be most important in moving a state forward, and that has the most evidence behind them. And Nevada's been working towards those. So next slide. All right, this next one is next steps in future direction when it comes to Mercer and working on your needs assessment report. Next slide. We have additional data resources that we recently received, like your Medicaid data and some tribal population needs. There are other things that we're looking at, or that we're waiting on to be ready, like some qualitative data to really dig in even further to what we found so far. We also know that we need to review some additional resources, like possible things that can be done for the rural and frontier areas that often are lacking in resources. So next slide. And finally, we presented this presentation to the Advisory Council for Resilient Nevada, or ACORN, for feedback last week. And during that meeting, they listed some additional topics and areas that they thought might be useful to consider for incorporation into the needs assessment. So those are that they wanted to see a little bit more zip code level data stratifications, some primary care and continuity of care. They talked a lot about a lot of people who are uninsured or underinsured may go to FQHCs. So really, I know Nevada is already starting to do it, but expanding more of that MAT service, or the medication assisted treatment service, in FQHCs as federally qualified healthcare centers that are mostly in rural areas, as well as rural health clinics, which are similar to FQHCs and kind of bill in a similar way. My understanding is the state has several reports that are looking at how to potentially increase the number of people that can get their opioid use treatment in a rural health clinic is a way of expanding. Mental health disease specific rates, they would like to see, among people with anxiety, how many have OUD? Among people with depression, how many have moved to substance uses? There's also, they wanted to see a little bit more about the child and adolescent substance use and overdose rates and risk factors, which we just didn't incorporate in the presentation necessarily. Looking closer at childhood trauma, which we will also do, and then additional harm reduction services that are out there. They also recommended some online or easily accessible educational resources, and then the inclusion in the report of the time and distance requirements for accessibility. Medicaid itself has some requirements for so many providers within a certain distance or amount of time of where different populations are. So they wanted to see a little bit more about where the treatment is. So this is all we have for now. What I believe we're hoping for is some feedback on additional, not resources, but additional things that you think are important to make sure we highlight in the needs assessment. And I would love to see if Dr. Woodard wanted to say anything more about the kind of feedback that the state also wants from the SURG committee in particular on what we've collected so far. But that concludes this part of the presentation if we'd like to have any questions.
Thank you so much. Let me defer to Dr. Woodard first to respond, if she has a response to your last question there.
Thank you, Attorney General Ford. Stephanie Woodard for the record. So in addition to feedback on the needs assessment, we really also believe that there's a lot of wisdom in the collective membership of this group. And so really from your areas of experience and expertise, being able to provide recommendations to Mercer on the needs assessment, as well as any areas that you feel need additional information or to be strengthened.
All right, thank you, Dr. Woodard. I saw a couple of hands pop up. I see Ms. Lee and Ms. Nadler. Is there anyone down here who wants to jump in? Okay, and then we'll come down here. Ms. Lee.
I believe Senator Duniate had his hand up first, so I'll yield.
Oh, okay. I can't see everybody on the screen. My apologies. So she's going to defer to you, Senator, and then we'll come to back to Ms. Lee. Senator Donate.
Thank you so much, AG Ford, and thank you, Ms. Lee. Really quickly, I think in terms of the needs assessment for substance misuse, I just wrote down 3 things in terms of recommendations. When we're talking about developing a better workforce in this subject space, I'd like for us to touch upon building a diverse workforce. I can't understate that with more importance, just because oftentimes to build on health equity, we need to have a diverse workforce to deliver on that. I'd also love to see how other states as you're doing your research and looking at what other states are doing, I'd love for you to touch on how we can close language access gaps as part of the needs assessment. I think that's definitely a part of the health equity conversation as well. And then last thing, I noticed towards the end of the presentation in terms of opportunity and strategies, there was a part of the presentation that mentioned programs that we can institute without necessary funding if it doesn't come through. I'd like for us to also consider the reverse. What are things that other states are doing in terms of permanent funding mechanisms in place to support this area? Because we are getting a historical amount of funding through this process, but it's not going to last forever. And I'd like for us to discuss some of the permanent funding mechanisms that we can have to support this public health space for infrastructure. So thank you so much.
Great points, great comments, Senator. I'm going to exercise a little executive privilege here and jump in right behind that, because I appreciate your notion about looking at more permanent strategies. Listen, we have some legislators in here, and I don't mean to put you on the spot, but I've been there before, and I know the difficulty around one of the pieces of conversation under the medical assisted treatment program, and that's reimbursement rates. Legislatively addressed, working with the governor and trying to figure out ways to increase reimbursement rates is something that falls within your purview directly. There may be an opportunity for some conversation around how these funds can assist in that regard, but I think that's certainly something that should be on the radar of our legislators here as we talk about more permanent ways of ensuring that we have some constant support. And then let me jump back out, go back to Ms. Lee, then we'll go to Ms. Nadler, and then I'll come down south here.
Chair Ford, Ms. Nadler had her hand up next, so I'll go last.
Okay. All right then, Ms. Nadler, go ahead. Can't hear you right now.
Can you hear me now?
Yes, go ahead.
Okay, I'm sorry about that. Thank you so much for that presentation. If we could have a copy of that, it's got some great information on there, but I do have a question. I noticed the number said 2020 and it gave the highest needs and everything referring to 2020. 2021 has brought out a whole new pandemic with the fentanyl. The numbers on there for the ages we're losing, I know per United States, it's 18 through, it's a younger age. Is the numbers that you put up for Nevada, does that coincide with the numbers for all of the United States? Are you finding the numbers in Nevada, the ages of the deaths in Nevada or are older, the percentage, because now they're younger?
So that's a really complicated data question. For the one, when it comes to 2021, since the year just ended, we won't be getting that information in for 6 months or more. Often there's a lot of things that have to happen, like medical coroner's reports take a long time to come in, can take several months. So it'll be a little while before we have 2021 data, but we have had some indications of, and that's part of what's good, getting feedback from you guys of what you're seeing and out there in the community. But I'm going to see if my colleague Jordan is on to talk a little bit more about, she's really, really into the data stuff and the local versus national and where the data comes from. Because honestly, even overdose data can look different depending on where we're getting it from.
I just wanted to say one more thing in regards to that. Thank you. As we know, the epidemic every year is changing. And with the rate of fentanyl, I personally lost my 13-year-old cousin to a couple months ago to fentanyl because nobody knows. Our kids do not know in the community. I stop every kid all the time and tell them about fentanyl. I know we want to work off of and correct me if I'm wrong on the wording of qualitative or quantitative roles that have been used in the past, but we're living in a different scenario. And I'm not sure how we can use qualitative and quantitative roles to assess what really needs to be done when we're at such a different earmark or in this whole epidemic. I've said it before and I'll say it again. If we do not get into the schools and educate these kids, we're going to keep losing more and more of them. The last question is Narcan. If we've seen a lot of incidences the kids are starting to use in middle school. I know there's Narcan in the high schools. Do we have Narcan in the middle schools in this state? Is it implemented? Is it mandatory? Do we know?
Well, I'm getting some head nods that yes, we have access to it in the middle schools. I don't know if it's mandated per se, but we certainly have our middle school students have access to it. Why don't we put a pin in that though and see if we can get some more definitive answers in that regard, Ms. Nadler? To your point about.
This is Barbara Collins from Mission High School. Okay. It's my understanding that CCSD has it in every level of school. Elementary, middle, and high school Narcan.
Very good. Thank you. Just because I've been seeing it in middle schools. Thank you. The last thing I want to say, and I promise I'm not going to say anything more, I promise. I have been begging for billboards to be put up all over our city. We've got it passed. We have them in LA and they are working. People are stopping. They are calling. I don't understand why we're not putting more into billboards on fentanyl and what is going on. Buses, bus stops, everywhere that there is. We've got to get the information out to the families. I was a Not My Child mom. Believe me, there's hundreds of thousands of residents parents who have no clue. It's so important that we give them the information on what is going on. And I'm sorry, that's all I have to say.
Well, thank you so much. I'm going to go back. I think Ms. Lee is next, but I think some of those questions maybe need, I don't know, Ms. Cantrell, do you have any responses to any of those statements?
Thank you, Attorney General. It was, and I'm sorry for jumping in and answering earlier without being recognized. It's been a while, but
all good.
But no, thank you. That's feedback that even if we get a question from you, we may not know, we're writing it down so that we can make sure that we address that in there. But I was going to see if my colleague can say anything about that difference in data you may see from national versus Nevada from 2021, and the fact that it can differ even from different sources we get nationally or about the state. Jordan, are you there?
Yes, thank you, Courtney. This is Jordan Bublick for the record. Regarding the data sources that were presented in this presentation, we were hyper-focused on the documents that were provided to us by DHHS, as well as working to update some of those rates. As Courtney mentioned, drug death data is very difficult. It's very there's a large data lag. Even if you review vital statistics data year to year, you'll see big changes. Even though the death may have occurred 2 years ago, it may not get counted right away. So we're working really hard with the state as well as national data sources to really find the most accurate and up-to-date information to include in the needs assessment. As far as your question regarding age groups went, the national 2019 data that the CDC has published notes that the 35 to 44 age group is where they're seeing the highest rate of overdose deaths. That is pretty close to what we're seeing in Nevada, though we have realized with recent data, there is a little bit shift more into the older population as well. And I know there was another question in the chat regarding the younger age groups, because we did not present that information. So I just want to let the group know that we are focused on youth, and we do have data available for youth overdose deaths. In our slide that we presented, it really gave the top 3 groups, but that does not mean that we were not looking at any of the youth rates, and we do have those available from this data as well.
Let me jump in right quick and say it's so great to have such great professionals here, because I don't know all of the bill numbers and the laws, but AB 205, naloxone in schools, there's a requirement under the statutes. And I don't know if that came through our current legislators or before that, but good stuff, y'all. Okay, I also just wanted to address, I think, oh my goodness, I can't remember the point I was going to make. So I'm just going to skip myself and go to Ms. Lee. Ms. Lee, go ahead.
Thank you, Chair. Dr. Cantrell, thank you for that awesome presentation. That was really great. And I hope you don't mind, I did take some screen grabs because you presented some excellent data.
We're actually going to distribute this, just so you know, Ms. Lee. Everyone's going to get a copy of this. And by the way, going forward, I've asked that we, all members, get a copy of any PowerPoint so that we can follow through as we're going through it. So you will get that on future meetings. Go ahead, Ms. Lee.
Perfect, thank you. Again, Lisa Lee for the record. A few initial thoughts. I was jotting down some notes here. One was to Ms. Nadler's point about the need for on-demand treatment. I know that this has been a barrier to access for a long time, especially given methadone treatment in particular. I did want to just point out here that the Life Change Center at one of their clinics now offers evening hours, which I think is really important for expanding access. And I just wanted to make sure that that information was publicly available. I also think that a few things regarding telehealth options to transgress barriers to access. I really think that we need more information on how that worked effectively during the pandemic and how that could be sustained over time, including adjusting some of the reimbursement rates and some of the exclusions to billing for telehealth, like for example, peer services. I think that it would be great to just have more information on that when we're thinking about expanding access and travel and all kinds of barriers. Another thing I would love to look at is funding and reimbursement for peer support specifically, and harm reduction outreach and engagement. We know that we need to meet people where they are, but there are very few funding mechanisms in place to ensure that effective harm reduction outreach is occurring, as well as peer support, people with lived experience going out there and connecting with others, and making those relationships, and also getting a feel for what's actually occurring, as far as drug supply contamination, et cetera. I'd also like to see, in addition to ACEs, like thinking about that really is prevention, not just for behavioral health concerns and substance, but looking over the course of life for public health or just physical health issues, and really exploring the relationship of intergenerational poverty, substance use disorder, and involvement with the child welfare system, and that impact on continued substance use disorder in adolescence and adulthood. I know anecdotally we see that. We tend to see, families just super involved. And really it's like, where do we intercept? Where can we effectively intervene so that we don't just continue these cycles endlessly? And really, I think that's the meat of prevention efforts as well. And then I did want to go back to the thing about supervised consumption sites, or what we called overdose and disease prevention sites in AB 345. That did not pass in the 81st session, but I did want to say that now we have new overdose prevention sites functioning in New York. We have legal precedent to challenge the so-called crack house statute and the Controlled Substances Act. So I think we could revisit that in a future session, hopefully. And then just anecdotally to Ms. Naylor's point about 2021 being a real beast. I know that in my own little sphere of family and friends, I have lost 11 people in the past 12 months due to drug-related harm or fatal drug poisoning. And so I have not experienced this since the 90s. I'm coming up on 20 years of recovery. And I haven't experienced this. And I just think about how that affects all of us that are really, you know, at ground zero, dealing with these challenges, just to have that re-traumatization over and over and over again. This is very real, and I know that data is going to be very ugly. So thank you for the opportunity to speak.
Thank you, and thank you likewise for making yourself vulnerable and sharing your story. Very touching. Let me see. I know we have down south here, Ms. Johnson. And is there anyone else down south before? Okay, and then Dr. Okay, everybody down here. All right, Ms. Johnson.
All right, wonderful. Jessica Johnson for the record. Thank you for a great presentation. Oh,
I'll get you next up in Carson City. I'm gonna run down here. I got four people down here, and then I come to Carson. Okay. All right, go ahead.
Apologies there. Again, Jessica Johnson for the record. Wanted to just echo a lot of what has already been said by the committee members and in the recommendation from the ACRN committee. So those were in my notes. I'll summarize those. I wanted to just reflect on some of the early conversation around primary prevention programming and the work with schools. That's something that I've heard in community conversations and in other work. So I'm curious about, you know, has primary prevention programming been really systematically and adequately funded across the state? And what are the barriers to working with schools and school districts? We have, you know, is there a way that we can learn about this from the higher education group statewide or from other school districts about barriers to evidence-based prevention programming happening in the schools? We have a, you know, wonderful network of coalitions statewide. And so I'm just, those were some of the pauses that I had when thinking about these prevention programming components. I also was thinking about in the systems level factors presentation, I was really wondering what specifically was hardest to fund with federal dollars out of the different system level factors that were presented. So meaning, is it easier to, you know, to address funding through for treatment services for XYZ population, but not, you know, general, or what does that look like? What does that access look like? And then I wanted to make a point about the polysubstance use graph, and maybe this is perhaps a question. I know this report is very much, my understanding of this report is focused on opioids. But I stood up to look a little closer at the polysubstance use graph. I thought that I saw that marijuana was highest in conjunction with polysubstance use. And I don't believe I saw alcohol included in that analysis. So I was curious what role those substances played when it, and I believe that the graph was on overdose deaths. I ran back to try to take some quick notes. So my apologies if I misinterpreted that. So I did have that question. And then to both Debbie and Lisa's point about fentanyl in 2021, the Southern Nevada Health District had looked at fentanyl deaths and non-fentanyl deaths by age, and that's where we were seeing the discrepancies. So for non-fentanyl deaths, they did mirror some of the conversation that was shared today with the older age groups, but looking specifically at the fentanyl related deaths was when we saw an increase for the younger ages. So I don't know if that's a planned part of analyses to look at some of those sort of intersections or cross sections, but wanted to share that in case it was valuable for the report. Thank you.
So thank you for all of that. Ms. Cantrell, I'm going to come to you for an opportunity to respond, but before we do, I'm going to call us a let's say a 7-minute break. 7 minutes to 10:45, however many minutes that is. 10:45, let's come back, and I'm gonna get started right back at 10:45. Okay, everybody, take a break, get some water, all that good stuff. Do you have a question, Carson, right quick, though?
No, we don't. We're just trying to hit the mute button.
Okay, all right. Okay, we've reached that hour, 10:45, time check. We have 45 minutes left for this meeting, okay? And we have three more substantive agenda items. So I want you to keep that in mind as we continue the conversation on this point. If you can keep your questions brief and responses brief as well, we can continue moving on. With that, let me go to Ms. Cantrell to see if you have any responses to the statements or questions that were raised by Ms. Johnson.
Thank you. If it's okay, I'm going to defer to my team. I think they have some answers for some of her comments.
Very good.
Good. So good morning, almost afternoon. I'm Kathy Nichols. I'm also with Mercer. I wanted to first just touch upon some of the things that are harder to fund with federal funding and some of the restrictions. And those would at a high level surround your social determinants of health. So housing and employment programs. Medicaid, for example, pays for rehabilitative services. So they would pay for services in support of housing, for example, but purchasing the housing, especially finding ways to get around background checks for people with criminal justice backgrounds and working with landlords and the housing development programming. Those are some of the areas that would require different sources of funding than your typical Medicaid and block grant dollars. Another point that I wanted to touch upon was telehealth, and that's a special area of interest to me and my subject matter expertise at Mercer. Not only can we talk a little further, maybe in a future presentation, about what other states are doing with telehealth. I've got a lot of information on that, but not enough time to share it with you at the moment. But in terms of funding things, broadband and equipment are two of the other elements that are difficult to there is a telehealth resource association, both nationally and regionally, that is available through SAMHSA and HRSA, but there is a lack of broadband nationwide, even in the more urban areas. So, and then of course, depending on the individual, they don't have either the laptop or even a smartphone to be able to access services, even if the broadband is in place, which in most rural and frontier areas is spotty and not as available. The other thing that I wanted to just touch upon briefly would be employment services and working with vocational rehabilitation to those activities. Then I want to just take a moment also to thank everybody, because we've had some excellent feedback and conversation from this group, and we've really appreciated some of your personal stories and the impact that we are seeing, that you're seeing having in your personal lives, as they're powerful stories to accompany the quantitative and qualitative data. And then just another touch base on schools. That is one of the multitude of reports that we are reviewing, and we should have more data for you on that in the next presentation. I believe. So we do have that information, but those reports came in after we had put this report together. So that's my hopefully brief enough answer. And I wanted to pass the baton to Jordan to talk briefly about the question about alcohol on the one graph.
Thank you, Kathy. Again, this is Jordan Bublick for the record from Mercer. For Jessica's question regarding the use of alcohol, we do have that information on, it's slide 8 of our presentation. It's the slide with the colorful hexagons. There is a rate for other contributing drugs for overdose deaths. The chart that we were all looking at on slide 17, which is the polysubstance use, that particular study was focused on, at the time, illegal substances. So that's why you're seeing more of cocaine and heroin, methamphetamine. At the time of that chart, I believe marijuana was still considered an illegal substance in Nevada. I know that recently passed, but I'm not sure that that had passed when that report was put together. So that's why you don't see something like alcohol. It doesn't mean that there is not data available that looks at all contributing substances, but that particular graph had a specific focus.
All right, thanks so much. All right, Dr. Woodard, is this in response or is this a new question?
Stephanie Woodard for the record. This is in response. I just wanted to add a little bit of detail related to some of the limitations as it relates to federal funding.
Okay, go ahead.
Thank you. Stephanie Woodard for the record. So to Jessica Johnson's question earlier, I do think that further analysis needs to take place as we push out recommendations for the utilization of different funds coming to the state to meet some of the needs and gaps. Many of the federal funds that the state receives through DHHS, specifically around substance use treatment and prevention, are categorical funds, meaning that there are federal regulations that stipulate how those funds can and cannot be used. And we have to make sure that we are staying within those regulations for compliance and reporting. In addition to that, a lot of federal funds come with mandatory set-asides, meaning that while we may receive $1 million in funds through the federal regulations, there is a portion of those funds that are specifically earmarked for different types of activities. And so again, that just puts further constraints on our ability to use those dollars flexibly. And then one of the issues that we continue to run into is that we don't know what kind of funding is going to be available year over year. So while we do receive block grants that are typically formula funds, all other funds that we're getting are grants that are time ended, meaning that we don't have the ability to really forecast long-standing sustainable funding streams simply using grants. So one of the primary strategies that we use is to ensure that what it is that we are funding with grants is enough to provide sort of proof of concept for different pilot programs, but to also work very diligently with programs from the very beginning around sustainability of funding. Any grant program that is 100% grant funded runs a very significant risk of potentially even doing more further harm to a community than not having that funding at all, primarily because we stand up programs only to then turn them down when that funding is no longer available. So from a DHHS standpoint, we do work very closely with our Medicaid partners so that while we have funding available, we're always exploring how we can work to make those dollars more sustainable through other funding streams. But the long-term sustainable, stable funding continues to be an issue when we're attempting to address things like recovery housing and harm reduction programs that typically don't have other funding allocated to them.
Thank you so much for that feedback. I'm gonna move over to Dr. Dixon. Mike's yours.
Okay, Dr. Dixon. So I want to address a couple things. One is workforce. We kick around all the time with workforce related to at least physicians, and I'm sure some of the stuff I say applies to my colleagues in mental health and behavioral health. In regards to the report, though, I would be real interested in what data you have that kind of indicates, you know, a little bit about who's prescribing, whose waivers are prescribing buprenorphine, because it's true, the SAMHSA list of those waivers is a huge list. We've got well over 200 in Clark County alone, and yet we know they're not prescribing. And I think sometimes, I think Dr. Woodard, you did do a little survey to find out what's going on, and we'd like to see that, what you found out. We're starting a project now to really try, I think we have a researcher to help us with this, to really start calling these doctors and see if they're really doing this, and if not, why not. I think part of the problem is going to have to go to reimbursement. And as you know, with the pandemic, a lot of people got put on Medicaid that were not on Medicaid before. Fortunately, Medicaid will pay for the medications, and we can, they'll pay us a small amount on our charge visit, but it's a small amount.
Right.
And it's, and then we have probably somewhere between 10 and 20% of, incidentally, I work for clinics that do methadone and buprenorphine. At the most 20%, probably less, of our patients are self-pay. In other words, they have insurance or they don't have anything. But we can't take insurance because for the doctor visits because their payment is so low that, and the way the things are written now, we can't charge the difference between what they pay and have the patient pay the difference for a charge. So we quit taking any private insurance long years ago because this is such a big problem. And if we don't solve this reimbursement problem, we're not going to make a whole lot of progress because these insurance companies, I don't know what they're thinking, that we should be able to get paid as little as we do for providing such a valuable service and preventing hospitalizations. Because these are people that are going to overdose or they're going to be in withdrawal. They end up in the emergency rooms all the time with one or the other. And of course, they end up in the morgue too. But it's very expensive to pay for hospitals. It's very cheap to pay for us. So we need to address that issue really. Now, one of the other things we're doing, I'm on the faculty now of the Southern Hills Residency program, and we have a new addiction medicine fellowship that started last year, and we have one fellow finishing up halfway through, but we haven't succeeded in getting fellows for next year. And we're not the only program with this problem. This year, only half of the addiction medicine fellowships filled nationally. This is not a popular specialty because for a lot of reasons, there's stigma and there's attitudes and all that, but I think a lot of it is the reimbursement rate too, is that it's just not cost effective to provide this kind of service. So that's what I have to say.
Thank you so much. Appreciate that insight. And Medicaid reimbursement rates has been a topic of conversation for a long time. So thanks for reiterating to us the importance of it. Let's move over here. I don't know who was first on my left over here.
Thank you. I'm Chelsea Cheatham for the record. I'm going to keep my thoughts really brief. Thank you, Dr. Pentrell, for the presentation. I just wanted to just kind of touch on some ideas that I had when I was listening. I already saw this in the next steps, but I definitely second taking a deeper look at harm reduction programs that are going on in the state, because I think those programs are doing some really innovative things. I know you mentioned the vending machine program as well as the shipping program, and oftentimes those programs have very little funding for syringes due to some federal restrictions on purchasing syringes. And then also, I think that I would like to see a discussion around the idea of mobile mat and just any restrictions or barriers to getting that started, whether they're federal or state level.
Great. Thank you for that input. Is there a response needed for that, or should we move on? Okay. All right, great. Assemblywoman.
Assemblywoman Claire Thomas for the record. Just to go back to something that we discussed earlier, inputs for financing. One area that I thought that we forgot to mention was the Native Americans, because we really do have a big problem. And for us not to include them, I think is one of our, would be great. As far as this committee is concerned, we would be at fault in not including our Native American community. And the other thing that, just listening to the feedback of some of the data that we've received here today, which I want to say again, Dr. Pentrell, that was awesome presentation. but my concern always is the why. You know, we can throw money, we can throw things that we think that will prevent this, I call it pandemic, that's addressing our community, our nation. But we need to find out why before we can actually get the problem solved. And I would just like to know, do we have any data? Do we have, you know, professionals that can give us that answer, especially in our rural community? You know, is it the lack of economics? Is it the lack of education? What is the reason? What's happening here? You know, I believe it was 28% of white males. I might be wrong with that, that are experiencing this addiction. So why? If we can, you know, get that answer, I think that I can better understand and look at all of the money that we will have in order to solve this problem.
Thank you for that. And I think to your point, slide 23 talks about Nevada vulnerability assessment. And I was interested to see that the 6 most vulnerable counties are Nye, Lyon, Story, Mineral, Washoe, and Carson. And if there is a correlation that we can draw as between, if it's not cause and effect, some level of relationship between what's happening in those counties and why they are listed as most vulnerable among the 17 that we have. That's a great question. And I don't know, to use a phrase that I think Ms. Nadler used, if it's qualitative or quantitative relative to the way we need to assess that. But it's an interesting phenomenon that certainly I think deserves some level of response. But let's see if anyone has any comments in that regard. I see Doctor. Go ahead, Doctor.
You know, it is since when you're a clinician, you're not thinking of collecting data, and so you just kind of get to know your patient. So I do ask every time with a new patient, how did they get started? And it has definitely changed over the last few years with the new laws about prescribing and keeping doctors prescribing of opioids under control. I almost never see a patient now that started with prescription pain medication, so it's very rare now. It's mostly younger folks who it's just what they're doing. They're just sharing drugs, and so it's usually a friend gave them some. And so why did the friends start? Well, they have friends that it's so culturally accepted, I think, within certain young people's populations. And then they only realize they're in trouble after about 3 or 4 years or something like that.
We appreciate that as some insight in that regard. And the other thing I'll say is this: is a preview of what's coming up in agenda item number 6. In our report, you'll notice, and we've talked about this already, and I'm glad that we keep saying it because it reiterates the fact that we think it's important. But disproportionately impacted populations are certainly going to, which would include our Native American brothers and sisters, will be certainly associated with the research that we do here. And that's going to be listed in our report that we'll get to in a little bit. So with that, let me move on to Carson City. I think we have some questions up there. Go ahead.
You're good.
Thank you so much. Good morning, Shayla Holmes. I just wanted to add, when we talk about ACEs, there is a significant body of research that's now shifting towards positive childhood events and how those counteract ACEs. And so I would be really interested to see what recommendations for effective youth programming in creating positive childhood events could be layered in with that. While we know ACEs leads to substance use and other behavioral health issues, how we can be more preventative and building more resilient youth. Being a representative from Lyon County and, trying to address that why when I see my county listed as top 5 on so many of those slides. And I think about what is available for our youth. I think about your vulnerable assessment and looking at our poverty rates and looking at our provider ratios and looking at our availability of transportation and access out. I think really getting to the bottom of how we build resilience in our youth will have a big bang for our buck on the preventative measures. Thank you, Ms. Nichols. You touched on my concerns regarding broadband and telehealth. Being a rural representative, I think anytime we talk about telehealth, I think that overlay of where broadband is accessible, and then when you think about poverty as a vulnerability factor and what that costs for somebody to be able to maintain, to utilize that as their main source, I think that always just needs to be something we consider. And the other thing that I wanted to point out or inquire on was local involvement in your needs assessment. So while you noted that 2 counties provide naloxone upon jail or community reentry from jail, I know Lyon, we do that, and we're not on that list. So it makes me consider what other local programming was not included in your assessment and how we might be able to aid in completing that picture.
Fantastic input there. I really appreciate that. And we certainly want to get that data corrected and as robust as possible. So go ahead, Ms. Cantrell, did you want to respond?
Or if you don't mind, it's just the Courtney Cantrell. The data that we presented to you guys is a sample. So it's some of what we read, we couldn't put everything in there. So those were just given as examples. I did note it, and if your county is not in there, then we do need to go back and see if there's some more detailed information, so that when we make recommendations and when we show you where the needs and gaps are, they'll be accurate. But just to let you know, just because it wasn't up there doesn't mean we don't have it as going into the report.
All right, thank you so much. Okay, was there anything else from Carson City? No? Okay, we're good? All right. A couple of thoughts before I move on. The broadband issue, just so you know, a different settlement that my office has negotiated with T-Mobile is working to get broadband into rural and frontier Nevada a lot quicker. So be on the lookout for some reports regarding that. We just heard about the cost of it, but it's not just cost, it's access as well. So we're looking to work, my office is looking to continue working with T-Mobile and others to get some access out to rural and frontier Nevada.
Chairman Ford, I apologize. It took me this long to unmute the button.
All right, yeah, go ahead.
Yeah, Dr. Cantrell, so there is a coalition in rural Nevada called the Resilient 8 Coalition. And we have done needs assessments for each of the 8 counties that we are part of that coalition. I'm happy to share those with you if they would be helpful. This is Eric Schoen for the record.
I'll speak, if I could just jump in. This is Kathy Nichols from Mercer again. We would ask that go through Dr. Woodard, all information that you might want to share with us. If there's other local programming or other information, she's sort of the holder of the seminal documents.
Okay.
So that we are making sure that there's not, we're not getting repeats of things she's already sent. So there's a central repository that's kind of being held there.
Very good. Okay, I'm going to get ready to wind this conversation up, but obviously I can't do it without hearing from Dr. Woodard. Go ahead, Dr. Woodard.
Thank you, Dirty General Ford. In addition, I just
Did you say Dirty General Ford? I think you said Dirty General Ford. Everybody else heard it too. Go ahead. I'm just messing with you, Dr. Woodard. Go ahead.
I want to make sure that also, as those of you who are representing local governments or have specific interests in a geographic region, that you're thinking about how you'll also be able to collect and provide this information to each of your counties. As it relates to the One Nevada agreement, there will be settlement dollars that are going to each of the counties as well. And really encouraging each of those counties and regions to conduct their needs assessments and develop what their plans are to be able to utilize the opioid settlement funds to meet the very specific and unique needs within each of those counties as well.
Thank you, Dr. Woodard. Okay, so listen, I'm going to go ahead and close this conversation. I know we can keep it going, but we have a few other topics to get to, the next of which is a very important one because we have a deadline coming up on submitting this report, and that is a review and provide feedback for draft annual report of the statewide substance abuse response working group for possible action. Dr. Kearns.
Sure. Thank you. And before I start going through this, I just want to thank SEI. They are the ones who collated this report for us. So kudos on you on pulling all this together. And just one other point, item number 4, the annual report on the use of state and local money to address substance misuse and substance use disorder. That is a DHHS report that will come to the SURG and provide us more information on the distribution of what's already being put out to our different communities. And that's different than our annual report, which I'm just going to talk about, that we have to then report on the work that's being done in the SURG, just for clarification.
That's helpful. Thank you.
Okay. So as we look at this, this report, as I said, that was pulled together and collated by SEI, is basically an overview from the statute from AB 3074. It lists our membership and summarizes the first meeting that we had on November 16th of 2021. And then once we finalize this, this will be the report that will summarize our findings and recommendations from the SURG. Next slide. And per the legislation, we have to submit this. As you can see on the slide, it will go to the governor, the attorney general, the advisory commission on the administration of justice, and any other entities that are deemed appropriate by AG Ford and the director of the Legislative Council Bureau. And then on the even number years, it goes to the Legislative Committee on Healthcare and the Interim Finance Committee. And the odd number years, it would go to the next regular session of the legislature. Next slide. And the context of this, just as we work through it, it's the working group members and the non-member roles. We'll go through the intro and the background, context for the report, roles and responsibilities of the SURG, the update on the opioid litigation for our state, and then the recommendations for that establishment, maintenance, expansion, or improvement of programs that address substance misuse and substance use disorders. And I do want to highlight on this, the SURG, we keep talking opiate. The SURG is all substances. So we are supposed to be addressing everything that we have. As we all know, methamphetamines continue to be a problem within our state. And then the appendixes just go over, we added the bylaws in that, SURG members by appointment, and then their biographical information. And that's the report that we've referred to a number of times already within this meeting. So next slide, please. As you can see, the statewide substance use response working group, this is a list of our membership that we all have. I will note that we have had one resignation because someone has taken a job out of state, and that's Danny Tillman. So we'll be needing to take up replacing her, and AG Ford will be in the future announcing her replacement. Next slide. In the context of the report, as you can see, this really, I'm not going to go through this in detail. It's in there. This is all of the information that comes directly from AB 374 and all of the 14 responsibilities that the SURG has been tasked with. So next slide. And again, this is those 14. I could read these to you. I'm not going to. You can see them, and you've seen these in our bylaws, and hopefully have seen them. This isn't the first time that you're seeing all of these roles and responsibilities of the SURG that are in this report. Next slide. So the update on the opioid litigation is, as you know, and has been talked about on the Attorney General's website, there's documents that include the declaration of findings, the second amended complaint, and that one Nevada agreement that talks about how the funding will be distributed between the state and the other counties or cities that also have litigation. Next slide. We also will go through the process. Oh, can you go back? Just one. The process is that obviously our case is unique. It includes defendants who were manufacturers, distributors, and pharmacies involved in the opioid epidemic. The discovery phase, and Nevada turned over 15 million pages and over 3 terabytes of data. Trial date is set for April 17th, 2023. The state will not receive a lump sum The process and the timing of recovering damages for harm will be different for someone who settles versus others who go to trial. And then the funding will be staggered. And the court may rule money will come in over a series of years. And this will all go into that fund for a resilient Nevada. Next slide. So we talked about the recommendations for establishment, maintenance, expansion, or improvement of programs that address substance misuse and substance use disorder. In that initial inaugural meeting, we focused on setting up the structural aspects of the process, and which limits the annual report that was provided to you. We'll have more robust recommendations through future meetings. Attorney General Ford was nominated and approved as the chair. Assemblywoman Tolles was nominated and approved as the vice chair. The draft bylaws were approved with one revision. Then the framework we discussed for the upcoming discussion was around the topic areas of substance use prevention, reducing harms, early intervention and treatment, recovery supports, criminal justice, and then data and information sharing. Next slide. And as we talked about the meeting considerations, about organizing the topics, we discussed having 2 at a time for the 2022 meetings, the timing considerations along how long those meetings should be, and also that we need information because bill draft requests will be due well before January of 2023, but our discussions can inform that process. Meeting length will be probably 2 to 3 hours in length, or longer meetings of 4 hours with a lunch break that cover 2 topics. Subcommittees were suggested to support deeper analysis and strategies to study the issues. Data is going to be important for all the future presentations over all of the different subject areas we talked about. And it will be the subject matter experts within our group that will be presenting those topic areas. Then we discussed regional information that's been successful and what to continue and what may be new or innovative. And then prioritization, unlikely we'll be able to accomplish everything ahead of our 2023 legislative session. So that prioritization is going to be critical. Next slide. And then there was discussion on criminal justice using the sequential intercept model of pre-justice versus re-entry programs. And there was a suggestion of dividing criminal justice into 3 categories: pre-incarceration, incarceration, and re-entry programs. We talked about prevention, children and youth attention, early intervention for children, and then the discussion of the Institute of Medicine's continuum of care, using universal prevention efforts, some selected secondary prevention, and reducing harm as considered a tertiary prevention. And then we'll explore health promotion and prevention to the group reducing harms, early intervention and treatment, and recovery support grouping. The CJ piece with the information and data sharing and how that may go across all of the groups. And then we may have overlap with public health and that opportunity for our subject matter experts to provide their input. We also talked about the social determinants of health and the impact that people's experience and cycles of isolation and poverty that will impact substance use. And then the SDOH in the rural Nevada as an important need for capacity. So having our State Department of Health assisting with the rural capacity. Child welfare systems and substance use viewed as separate from criminal justice system. And then for opioid use in particular, recently published research shows a correlation between overdose rates increasing where child welfare rates increased in communities. Then talking about statewide efforts to incorporate the KIRA plans of care and Family First Prevention Services Act. And then overdose prevention would hold its own place. Next slide. And then the next steps were the suggestion of topics and subtopics. And the suggestion was made that any topics or subtopics should be attached to items A through Q of our bylaws and the legislation to determine where they would fit within the scope. Just of note, I didn't receive anything from anyone, so if anyone still has anything they would like to address, please send it to me. And then the state contracted vendor will bring forward the initial findings for the state needs assessment in the January meeting, which we just had that discussion. Next slide. And the appendix for this report are our bylaws, which were approved with the one revision, the SURG membership by appointment. So everyone's position and what they're covering within the legislation, and then the SURG members' biographical information. So that's what all is contained within the report. We have it for action. I know that AG Ford suggested already that we also provide the update on the opioid litigation about the funding that we've already received and the funding that we will be receiving this year, and that 95% of that we should be receiving this year, and then our grant that we also received. So I will open it up at this point to any questions or comments on that report.
Well, let me first just say this is excellent. Good job you working with others to get this together. I'm very impressed with what we have here, and I don't mean to like poison the well by offering my initial analysis, but I think it's great. So I do think you should double check with Mark Kruger in our office to get a complete update of where we are on the litigation. He can give you, he's very good at quickly returning information you need. So do that. Let's open it up for discussion. We do want to ultimately approve this with recommendations to change certain things if necessary. I see Ms. Lee's hand up. Go ahead.
Lisa Lee for the record. You know, I'm going to say something about language here. So I saw in the presentation that substance use and misuse was used. However, all throughout this document, I've highlighted on my copy where the term abuse was used. So I would hope that we would have consistent language that matches kind of, you know, non-stigmatizing use of language. So substance use or misuse instead of abuse. And then the other suggestion is on page 10, Article 2, Section 1, that very last sentence, it says, and harms of substances abuses. I would hope that we could change that to substance use or misuse. And then my other question, I guess, is regarding terms. I just think about the brain drain from attrition, and I know that people can opt to or be appointed to serve another 2 years, but my worry about not having staggered attrition dates is that you would lose a whole bunch of folks with a lot of experience and without that knowledge transfer. So I don't know if that's something to consider, is to have those staggered dates. And I know that doesn't match with the language associated with that 2 years, but I can tell you as a chair of a state group or state board, we did kind of change the initial term dates to avoid that attrition at the same time. So just a suggestion. Thank you.
All right, thank you. No, I appreciate that last suggestion. We'll have to put some thought in on how best to address that. Relative to the changing of terms, I think that's fair and appropriate. And of course, I'm glad that you're on the committee so you can remind us of this. I have my DAG on the line, and what I'd like to be able to do is to the extent we are going to accept recommendations from folks to amend this, to allow those recommendations to go directly to Terry Kearns so that she can update it and get this out, contingent upon our yes vote today. And we just, as a committee, we'll just trust that those edits are going to be made and we can submit our report by the end of the month, because we won't meet before the report is due. So DAG, who on the line, am I wrong about that? Can I do it that way?
He's muted.
Oh, you're muted. Still can't hear you, my man. Give me a thumbs up. Can I do it like that? All right. Okay. Okay. All right. If not, come down and see me. If you are here, just come on down here. If not, then I don't know. We'll figure something out. Thank you, Ms. Lee. I see Ms. Nadler's hand up. Go ahead, Ms. Nadler. You're muted.
I'm sorry, I should know better. Thank
No
you.
problem.
This is Debbie Nadler for the record. About the earmarked funding that's coming from the federal regulations and the funding, will we receive a report on what is earmarked and how much is earmarked for whatever it's earmarked for, so we can make our recommendations based on what's already earmarked? If that makes it, I don't know if I'm saying this correctly, but
Yeah, I think I understand your question. The short answer is yes, there's a reciprocal exchange of information that's going to happen with the Fund for Resilient Nevada, the committee that's overseeing that. They're making the decisions. We don't. We make recommendations, but whatever decisions and recommendations they're contemplating, we will get information on, and we can, operate off of that information.
okay. And then the last thing, I'm sorry about this. I know you said we've received 285 million from
More than that, 335, I think. Go ahead.
Right. Well, because the 45 million from McKinsey. So is that for immediate use? Because we have immediate needs in this state, obviously. Is that for immediate use recommendation? Anything, that money that we have?
Well, as the money comes in, it goes to the Fund for Resilient Nevada, and that committee is already allocating monies associated with how it's going to be used. Yes, it is for immediate use once we get it in.
Okay, thank you.
Absolutely. We'll be getting in additional monies in April, I want to say, from two of my settlements that we just announced, and maybe even before that too. So yes, but it's going to them, and it's going to be distributed to counties pursuant to the One Nevada agreement, but also to the state based on that agreement, and they can, and the state will determine how to spend its portion of that money. Any further questions, comments on the draft? Assemblywoman Tolles. Yes, ma'am.
Yes, thank you so much, Chair and Attorney General. First of all, congratulations again. Thank you for how hard you're fighting for those funds. Every time I see a new announcement, I'm just so proud of the work that your office is doing, that we're doing in the state of Nevada to meet these needs. I wanted to see if perhaps we could hold off the vote on this until after we address the next two agenda items, which is the establishing priorities and process and the reviewing the considerations for the next meeting. But specifically that agenda item number 7, I wanted to suggest a structure for the subcommittees in particular that may help us to break down this enormous work that this entire SURG group is committed to. And I think that that would be important to include that structure in this report. And so could we perhaps pause here before taking a vote, have that discussion so that we can incorporate what that structure is for those subcommittees into that report?
So the short answer is yes, but the long answer is this. It's yes, but if we are willing to go beyond 11:30. Because if not, then we don't have the ability to do that. But that doesn't preclude us, Assemblywoman Tolles, from incorporating your suggestions on committees on a going forward basis. It just won't be in the report that we have to file. What's your, I mean, I guess if you got to go, you got to go. Why don't we accommodate Assemblywoman Tolles' request here, put a pause on that agenda item, move down to the committee discussion, and then we'll come back, incorporate that hopefully, and then vote. So if you have to leave, my apologies. I tried to be cognizant of our time, but we got work to do. So with that, Assemblywoman Tolles, we're going to move to agenda item number 7 to review and consider items for the, is it? Yeah, am I right? Am I looking at the wrong one again? I'm looking at the wrong agenda item again. All right, number 7, establish priorities and processes for the upcoming year to accomplish the business of the working group. And by the way, if you had additional comments on the draft report, hold those. We'll come back to it in just a second. Assemblywoman Tolles, let me give you the floor so you can discuss the items you just mentioned.
Thank you so much, Chair. And thank you, Dr. Woodard, for letting me jump in on this agenda item. So as we look at this enormous task before us and all of the duties of this working group, and as I reviewed the report and the minutes from last meeting, it appeared to me that we plan on having quarterly meetings as an entire SURG committee, but to get the work done, in your own words, Attorney General, that you want this to be a working group where we actually produce results that we'll need to drop into subcommittees. I know it was recommended perhaps that we drop into 2 subcommittees. I'd like to suggest maybe 3 may help us to break the work up a little bit more equitably. And as I've listened to the discussion today and also reviewed the discussion from the November meeting, it seems that I'd like to propose that we could fit these into 3 different buckets. There's the prevention piece, which I heard very loud and clear from Ms. Nadler, that and others, that it's important to keep that distinct, because there's distinct duties that come with that. The second piece would be the treatment piece and how we're treating it and access to treatment, and what programs are working, what recommendations are evidence-based that we can make at the end of this report. And then the third piece I would title, and I'm open to suggestions, but response. And that would include community impacts, criminal justice system, harm reduction. And I know that there is crossover between all 3 of these, because if we're doing harm reduction, we're also helping with prevention with the next generation. And we know that all these are tied together, but I think that's a way to take this elephant and put it into bite-sized pieces. And then the recommendation would be to then have each of those working groups meet monthly, identify not just who and the members want to be in those working groups, but which outside collaboration of groups that specifically specialize in prevention, treatment, and response could participate in those working groups, identify their own list of subject matter experts, what they think are their recommendations, and pull together those recommendations on policy, on expenditure of funds, and any other actions that can be taken outside of those 2 categories. And then come back and report to our quarterly meetings on the progress. And then we can set up a timeline of what action steps we can accomplish at each of those quarterly meetings, so that we're ready with the yearly report by next January, and any other action items we can take as appropriate before that point, whether it be for legislation for BDR requests or other public campaigns, et cetera. So I just wanted to lay that out there as a framework that I think could help us to execute on this large list of duties. I'm certainly not married to it, and absolutely willing to listen to feedback from the group, but I wanted to get that on record so that we could hopefully incorporate that in the report to reflect the number of subcommittees this SURG group agrees to. And then before we leave today, we can assign the task of requesting who wants to be on which committees, who else they think should be included, and what subject matter experts they would like presentations, or what presentations they'd like to receive, so that they can then begin that work. We can formalize it by the next March meeting.
Very good. Thank you, Councilwoman Toles. Let me open it up for a response to that. I don't know do you want to say anything, Dr. Kearns, at this juncture, or I don't want to put you on the spot.
Yeah, no, I'll defer to the group.
All right. Anyone have any responses or commentary based on what we've just heard? Because I do. All right, Ms. Nadler. Go ahead, Ms. Nadler.
I 100% agree. I think that's a fantastic idea, and I'm open for it. I think it's a great idea.
Okay. Any others? I can't see anybody else. Anybody else?
I don't see anybody.
Okay.
Here.
Oh, I'm sorry. Ms. Johnson, go ahead. Yeah.
Jessica Johnson for the record. Thank you, Assemblywoman Toles, for kind of thinking through and suggesting this structure. Not to add more groups, the only area, and maybe this was included when you were thinking through response, might be recovery. So thinking about kind of the prevention work, the responses within community, work around treatment, and then recovery. I didn't, in your conceptualization of this, was the thinking that the recovery work would be within the response kind of components. I'm thinking through that, or did it lie elsewhere? That was my only question. The other three categories really made sense in that conceptualization.
Assemblywoman?
I am certainly open to the feedback of the experts in this committee, but the way that I conceptualized it was that recovery would be part of treatment and that response would address some of the more community impacts or the ripple effects, everything from criminal justice to family impacts to the impacts on homelessness or other issues that are the result of these issues that we're discussing. But I'm certainly open to discussion on that.
I would actually co-sign what you just said about leaving recovery and treatment, or however you just said that, but for a couple of reasons. Logistically speaking, we can only have 3 subcommittees because of resources. So we would want to ensure that we can have this fit within that resource barrier that we have. If there are no other questions on this, I will suggest that we adopt this suggestion, add it to the report, and as she's indicated, take names of folks who want to join the particular subcommittees today so that people can begin the subcommittee work. Let me remind you that the subcommittee work is work for this office, it's work for Dr. Kearns, it's work for Dr. Woodard as well. So we want to be very cognizant of that fact. These aren't, it's a lot of work. So keep that in mind. If we're going to do this, we want to be certain that we're not wasting people's times and we are being cognizant of the fact that they are taking time to work on these things too. So with that, is there any objection? Okay, let's add that to the report. Now, what I'd like to do at this point is, before we, I know I'm jumping all over the place. I don't want to take the names yet for the committees unless you think it needs to be in the report. Assemblywoman.
No, Chair,
Okay.
I would recommend actually that we would give the members here an opportunity to, we could send out an email or even a survey saying, please let us know which group you would like to work on. If you're willing to chair or vice chair, what other stakeholders across the state you'd like to see, what topics you'd like more information on. And we can get that survey and then we can announce those committees and chairs and vice chairs at the March meeting. That would be my recommendation for time's sake.
Terry, can you handle it? Okay, all right, that's how we'll do it. Very well, I know I'm over the place. We're gonna jump back now to number 6. With the instruction to incorporate what we've just heard relative to the subcommittees. And I'm going to ask if there are any other questions, comments, concerns, additions to agenda item number 6. All right, hearing and seeing none on the screen, right? Hearing and seeing none, I will entertain a motion to adopt the report as amended today with instruction or with authorization for Dr. Kearns to submit the report by the deadline.
So moved, Chair.
All right. I have a motion from Assemblywoman Toles and a second from Dr. Dixon. Any discussion on that motion? Hearing and seeing none, all in favor say aye. Aye.
Aye.
Any opposed? Thank you. Any opposed? Any abstentions? Motion carries unanimously. Thanks so much. Good work, everybody. Thank you so much. Okay, we are at 11:37. I think I'm going to take some more privilege and continue us moving. We can finish this agenda out. Let's go back to number 7 now and talk about additional priorities and processes for the upcoming year to accomplish the business of the working group. Dr. Woodard, you were the chair, you were the spokesperson for this particular agenda item. Is there anything else you want to add?
Thank you, Chair. Not at this time. I feel like we just covered a lot of ground with determining subcommittees. Those subcommittees will then, I think, set forth the work that needs to be done within each of those committees as well as membership between now and the March meeting. So I believe we've covered ground, but I defer to you.
Okay, I have nothing further. Is there anything further on this agenda item from anyone else? All right, hearing none, we will go on to number 8, to review and consider items for the March 9th, 2022 SURG meeting. Dr. Woodard, back to you again.
Thank you, Chair. Stephanie Woodard for the record. So to date, I believe we have 2 agenda items specifically for the March meeting. The first would be to review the information that Assemblywoman and Co-Chair Toles just mentioned around the membership and the topics that will be covered by each of the subcommittees. And in addition to that, we did establish the March meeting to ensure that we have ample opportunity for this group to review a draft of the state plan that is generated out of the Advisory Committee for Resilient Nevada toward the direction of funding for the Fund for Resilient Nevada. Those are the two primary agenda items I know we anticipated tackling in that next meeting. So I think if we could, Chair, open it up to the other committee members to see if there's additional work that we want to accomplish during that March meeting.
Yeah, my bad. I was on mute and I was just saying that. I wondered if you were suggesting that we consider other things on the agenda. It sounds like a lot already to review the state plan, but I'm open. Anybody want to say something next go around?
Chair, I just wanted to ask if we would have a progress update on the needs assessment that DHHS was going to incorporate all of our feedback on. Is that going to be included in this review of the current state plan, or would that be, could that be a separate item?
It will, Dr. Kearns?
Yeah, we have that listed, and I would defer to Dr. Woodard if she wants those as separate or that all in one. So do we want the final needs assessment review as one item and then the draft state plan as a second, or do we want those to get separate? Okay, so then that would be those two separate areas of one, reviewing the final needs assessment, and two, reviewing the draft state plan.
Does that answer your question, Simone Toles?
Yes, thank you.
Okay. All right, I thought I saw a hand. Anyone else?
We need to have the appointment, your new appointment.
Yeah, we'll be appointing someone to fill the vacancy in the board. That's an agenda item. All right, here's what we'll do. If you have recommendations between now and the next agendized meeting, please submit those to Dr. Kearns, and we will, and she'll consider that based on the timing that we have for that meeting.
I have just one other thing. Do we want to try to put the March 9th meeting as our date for having the membership for the subcommittees and suggest?
Yes.
Okay, we'll put that on for the next agenda too.
Yes, ma'am, go ahead.
Hi, Jessica Johnson for the record. With regard to the subcommittees, looking forward to kind of hearing how that comes together. I was wondering if included in that, we might consider kind of a framework. So I know we had talked about maybe community partners and some other pieces of discussion, but a framework for those particular meetings, meaning will they be considering kind of the data? It sounds like data and community programs and topics, et cetera, so that we can return to this group sort of with the most robust findings based on those pieces. Maybe that framework already exists within the legislation and I'm still learning about it, but I think that would be really beneficial so that we're asking similar questions about the multiple stakeholders in those locations.
So I have a response, but I want to hear, and hold up, I'm sorry. I see Joel Becker's hand. Joel, that's my dad. Am I in trouble? I can't hear you though.
I can't hear.
Can't hear you, Joel. No. Can you call me from your phone? You're gonna come up? You're gonna type it, okay. All right, he's gonna type it and someone needs, all right, but I'm gonna hold up until I hear from him because I don't want to be messing up right now, so.
In the chat, someone Toles has their hand raised.
Well, I want to wait, Simone Toles. I want to hear what he has to say in case I've been messing up.
He said, just a reminder that yes, no votes on subject should be verbal for the record.
Okay. All right, he says we have to, I don't know if I missed the vote, but when we vote, we have to be yes, no, verbal, not just by hands. So, okay. I don't think I missed the vote like that yet, right? We all voted yes on everything, I think. Okay. Do I need to redo something, Joel? Put that in the chat if I need to redo something, okay? Because I'm not quite sure that what you're saying there. Assemblywoman Toles, go ahead.
Thank you. I was just going to say that I'm happy to work with Terry on that framework. Just to lay out a vision, when I was vice chair of the task force for school safety, the school safety task force, what we did was very similar to that structure. We broke into working groups, and each of the working groups worked off of an Excel spreadsheet that each member would add what their recommendation was, how it met the requirement of the task force, what research or evidence-based programs or methodology that they could link to it, and what category it would fall into in terms of type of recommendation. Is it a budget recommendation, whether that's the use of budget dollars, grants, state donations? Was it a policy recommendation that could turn into a BDR request for the next legislative session? Or was it another type of recommendation that could be executed through our partners more immediately without a need for budgetary approval or for policy passage? And that was just a very clean and easy way to work through this behemoth of a process to execute on recommendations and action steps. And so that would be my recommendation. And I'm happy to work with the team to put that together.
I love it. This committee has great members. Thank you, Superwoman Toles. We're going to rely upon your expertise in that regard, and absolutely work with Ms. Johnson and Dr. Kearns on this as well. So, all right. Any further questions, conversations around number 8? Hearing and seeing none, we will move on to agenda item number 9, public comment. Is there anyone on the screen for public comment?
We do have a Rhonda Fairchild. I'm going to allow her to talk. She has her hand raised.
We have a Rhonda Fairchild on for public comment. Ma'am, you are unmuted. Go ahead.
Thank you. Rhonda Fairchild for the record. I have a comment on the assessment needs report. And I would just like to see more information about Nevada Department of Corrections, like recidivism rates, any substance use data reports that they have, also in any incarcerated individuals. So Clark County Detention Center, City of Las Vegas. I'd like to see more data on that concerning SUD data. That's it. Thank you.
Thank you very much for your public comment. It will be noted in the record. Thank you so much. Anyone else for?
No, we just have Lisa Lee, one of our members.
Okay, and Ms. Lee, you have a question, a comment for public comment?
Yes, thank you, Lisa Lee. For the record, I just wanted to invite everyone on behalf of Washoe County Human Services Agency. We will be hosting an event on March 4th, 2022 from 8 a.m. to 5 p.m. at the Renaissance Reno Downtown Hotel and Casino, with a virtual option to attend as well via Zoom. Here's the title, March 4th for Reproductive Health, Prenatal Substance Exposure Learning Series #1. It is part 1 of a multi-part learning series on the topic of prenatal substance exposure and substance use disorder. So we invite you all to attend. If you would like to be added to the list as I send out RSVPs, etc., my email is L as in Lisa, C as in cat, Lee, Lee at washoecounty.gov. Thank you.
Thank you, Ms. Lee, for that announcement. Any further comments during public comment? Ms. Nadler.
I'm sorry, last one. As long as she was talking about an event, we have a big event. Maybe everybody in here knows about it. It's run by 10 High Las Vegas. It's February 7th, and it's open resources for all. Big event. It's Central Church in Henderson, starting at 4:30 to, I want to say 8 o'clock. Lots of resources there. If you go to 10 High Las Vegas on Facebook, it's got all the information on there for the event.
Thank you, Ms. Nadler. Any further public comment? Okay, hearing none in writing, right? We said hearing and seeing none. Then I don't need a motion, so I will call us adjourned. Thanks, everybody. Great meeting. Have a great rest of your day.
Thank you.
Thank you.
Can you hear me now?
Yeah, perfect. Right on time, Joel.
Perfect.
Right on time.
It was a pleasure. Thanks for everything.
Thank you. That's hilarious. All right, we hung up?
Yeah.
All right, bye, y'all.
Thank you. Thank you.